All right, well, it is 1:02, so we will go ahead and get started with our BHA rules town hall for chapters 3 and 4. Go on to the next slide. All right, so we like to begin all of our presentations at the Behavioral Health Administration with our BHA values. These are values that we really worked hard to develop and really guide our work on a daily basis. And we're really excited to share those, which are truth, equity, collaboration, community-informed practice, and generational impact. So these are things we keep in mind on a daily basis as we are drafting rules, as we are doing all the other functions the BHA does, and just like to make sure that everyone is aware of what those values are and how they show up in our work. Next slide. So welcome to today's town hall. I see some familiar faces who have been at other stakeholder meetings, and this specific opportunity is a detailed review of chapters 3 and 4. Chapter 3 is our safety net approval process, and chapter 4 is our care management endorsement for comprehensive community behavioral health providers. So this one is going to be a more presentation and content heavy presentation. We will be going through chapters 3 and 4, so no worries if you have not read those. At this point, we will be reviewing them, and I want to note that anyone who was with us this past December and January for our meetings, we have made changes to the chapters since then. Some of those are based on some statutory changes that came with this last legislative session. So we will be highlighting all of this new content in chapters 3 and 4. We have additional opportunities coming forward after today. This is a more presentation heavy, but we also have a number of more discussion-based opportunities. So we have drop-in office hours that are virtual where people can come in and provide feedback or ask questions about any and all rules. We have listening sessions for individuals with lived experience coming up. Those start next week. We have a couple in English, one in Spanish, and one in American Sign Language. And we also have a number of in-person opportunities throughout the state for those listening sessions where you are welcome to come and we are going to spend a couple hours with you and just listen to what your feedback, questions, concerns regarding the regulatory update are. Next slide, please. Today, we are joined by a couple of American Sign Language ASL interpreters. We have 2 interpreters that will alternate throughout the session. If you would like to have these easily available, you'll want to pin these boxes to your main screen. This is ASL interpreter Julia and ASL interpreter Tiffany. So you will select gallery view in the upper right-hand corner. Click on the ASL interpreter screen and select the More button, the 3 dots, pin the video, and you'll repeat this process for the second interpreter if you want to make sure those are visible to you at all times. And thank you to Julia and Tiffany for their assistance today. A couple of housekeeping items before we begin. As I mentioned, and as you may notice, we are recording this video and we will be posting it on the BHA website. So if anyone was not able to join, they can review this later, or if you would like to review this content again, we will also have the slides available on the website as well. BHA staff have access to the chat and transcript to ensure that comments and questions are captured, and we encourage you to share whatever you are comfortable with in this venue. We're happy to see a good crowd with us today, so really appreciate you taking some time out of your afternoon to chat through these chapters. You are welcome to share input through the chat function. We also have an email inbox, cdhs_BHA rule feedback @state.co.us, and we will be dropping links in the chat throughout the presentation, including that email. We have a Google form and survey that you can submit feedback through. You are also welcome to raise your virtual hand. We're happy to have you come off mute and have a chat with us. And you can also reach out through the email or Google form if we do not get to your question or feedback today in this venue. Before we get started, I will start with a few BHA staff introductions. So my name is Victoria Lasky. My pronouns are she, her, and I am the Safety Net Associate Director at the Behavioral Health Administration. I'm going to pass it over to Tom Miller to introduce himself, and then we'll introduce our speaker.
Thank you very much, Victoria. Pleased to be here this afternoon with everyone. Tom Miller, he, him, his pronouns. I'm the Division Director of the Quality and Standards Division. Did you want to go back to Erica, or should we introduce Ryan?
Let's do Ryan as well. See that he's
Ryan, over to you.
Good afternoon, folks. From Ryan Templeton, he, him pronouns. I'm the Division Director for Policy and External Affairs with the Behavioral Health Administration. Yeah, thanks for being here. I'm excited to talk about rules as well. So, into the next.
Thanks, Ryan. My name is Erica Gannett, and I am a Safety Net Licensing Manager here at the BHA. One of my primary roles on the team has been drafting chapters 3 and 4, which is what I'm here to talk with you all about today. So excited to dive into this content. So just an overview, as Victoria mentioned, we have made a number of changes based on both statutory updates and previous stakeholder feedback, and we'll be highlighting that today. Just to start with a couple of those changes. So House Bill 23-1236 made a couple of updates both to our timeline and some of the content of chapters 3 and 4. So first of all, many of you have probably heard this already in other presentations, but all of our provider rules have been delayed until January 1st, 2024. So that includes these safety net rules, as well as BHE and 2765 rules. Additionally, the bill clarified the behavioral health safety net providers are essential behavioral health safety net providers and comprehensive community behavioral health providers. There was some vague language in there previously, and now it's clearly defined that these are what we're talking about when we're talking about behavioral health safety net providers. That's clarified through the definitions in the bill. And then it also expanded the services for essential providers, which I will go into a little bit later here. So where we've been and where we're going, just to, again, frame some of the changes you will see. So if you've been tracking with us since the winter, you'll see that there are a lot of changes to chapters 3 and 4. The big change that we want to make sure is clear going into today's forum is behavioral health safety net provider approval is optional. So our original versions of chapter 3 were including a broader scope of providers and not just providers that are choosing to opt to become essential and comprehensive providers. So as of today, what you will see within these chapters, and the chapter is posted online, so this isn't a today change, but what you're seeing right now is that providers are opting in as either comprehensive or essential providers. And in doing so, they're agreeing to serve all priority populations, provide care coordination, and meet additional standards in alignment with the safety net system competencies. Providers receiving public funds and serving Medicaid members are not automatically safety net providers per these definitions, nor are they required to apply to become safety net providers. So we just want to be clear about that distinction. And then the approval that we'll be talking through today that's outlined in chapter 3 is required in order to be eligible for enhanced payments that HCPF will be administering to approved behavioral health safety net providers. And we also just want to make clear that licensure requirements, so being a BHA or other obligations that a provider may have to be licensed by state agencies, are separate from safety net approval. So just because you're a BHA doesn't mean you have to get safety net approval. Just because you're getting safety net approval doesn't mean you're automatically a BHE. That requirement for a BHE is separately defined. And if we have questions about that today, we can certainly touch on it. We went deep into that in our last town hall on chapters 1 and 2, and you can definitely reference that. Also, those slides are available on our website, and a full recording of that town hall is on our YouTube channel. So in terms of care coordination, to clarify some of the changes, you will also be seeing care coordination requirements for different types of providers have now been built into the provider rules across the continuum of care. So chapter 3 used to define multiple levels of care coordination. I would say it was a little unclear on who was required to be fulfilling each of those different levels and where that all, what that all meant. And so what we've tried to do is clarify that. The basic care coordination requirements, really navigation requirements that BHEs have live directly in chapter 2. Chapter 3, which has the rules for behavioral health safety net providers, both essential and comprehensive, has the care coordination requirements that those providers are held to. And then chapter 4 is the care management endorsement that is specifically for comprehensive community behavioral health. So we'll talk about all the services that comprehensive providers are required to provide. Care management is one of those. And so chapter 4 at this point is only applying to those comprehensive providers that are required to get endorsements for each of those services. So with that, the care coordination rules that you'll be seeing today in chapter 3, accompanied by the care management rules in chapter 4 and what I've referenced in chapter 2, are just a small piece of the care coordination system and infrastructure. So these aren't the rules for the whole system. There's a lot of work going on across our divisions, the BHA, and with our state partners to build out this infrastructure, ensure that it all lines up and works. But those timelines aren't all in line with the work that we're doing on the rules here today. So BHAs have been delayed until 2025. The rules that will clarify the role of BHAs and the BHA in what the BHA will be doing for care coordination, as well as the continuum of care as a whole. All of those rules will live in what we're calling administrative rules. It's a separate rule volume. It's not what we're talking about here today. So those service access requirements and the care coordination system rules and requirements are separate from these requirements that are just the requirements for specific provider types that will be, today we're talking about approved by the BHA. When we talk about chapter 2, those would be those licensed providers requirements. All right, so I'm going to dive into chapter 3. Feel free to post questions in the chat or raise your hand as I go. I see Victoria is responding to questions already. I can't see the chat at all times while I'm presenting, but I will let my team interrupt me if I need to stop and clarify something based on anything in the chat. So diving into chapter 3. Chapter 3 outlines safety net approval, and this chapter is the standards and approval process for behavioral health providers opting to become essential behavioral health safety net providers and comprehensive community behavioral health providers. So just overarching current state, what we see, unfortunately, is that people are sometimes turned away from services for a variety of reasons. And in establishing this behavioral health safety net, the future state, the goal is really that this safety net system is one where people cannot be turned away from care due to things like their ability to pay, criminal justice involvement, co-occurring disorders or disabilities, and more. Additionally, right now, current state specialty providers that may not provide the full range of services and aren't fully incorporated into the safety net system, fully incorporated into the safety net system. And future state is this addition of these essential providers who provide a subset of services and serve some or all priority populations. And those providers are able to be fully incorporated into the safety net system. So when we're talking about that safety net system and who makes it up, I've said these terms multiple times, the essential and comprehensive providers. But when we're talking about essential behavioral health safety net providers, we're talking about providers that are providing care coordination and one or more of the services that you're seeing on this slide on the left side. So emergency and crisis services, outpatient services, intensive outpatient services, residential, withdrawal management, inpatient, integrated care, and hospital alternatives. So a provider providing one or more of those services can opt to become an essential behavioral health safety net provider or can apply for approval. On the other side, comprehensive community behavioral health providers are providing care coordination and all of the following services, either directly or through contract. And those services are emergency and crisis, outpatient, intensive outpatient, recovery supports, care management, outreach, education and engagement, and outpatient competency restoration. So these comprehensive providers are required to provide all of those services, whereas essential providers may be providing one or more of the essential services. To go over some requirements that apply to both of those provider types, one of the first requirements that you'll see in the rules is this no refusal requirement. We'll walk through a number of different pieces of this and how this really gets integrated into the system, what this means for providers that are approved to serve subsets of populations. But this is the statutory language, and we just want to kind of put this out there first so that we know what we're talking about when we're talking about this no refusal. So unless the individual exceeds the clinical capacity or expertise of the safety net provider, no individual shall be refused care. There's a typo here, I apologize. But no individual should be refused care based on insurance coverage, clinical acuity level, readiness to transition out of a mental health institute or inpatient level of care, involvement in the criminal or juvenile justice systems, current involvement in the child welfare system, co-occurring mental health and substance use disorders or physical disability, intellectual or developmental disability, irrespective of primary diagnosis, co-occurring conditions, or if an individual requires assistance with activities of daily living, displays of aggressive behavior or history of aggressive behavior as a symptom of a diagnosed mental health disorder or substance use disorder, clinical presentation or behavioral presentation in previous interactions with a provider, place of residence, and disability, age, race, creed, color, sex, sexual orientation, gender identity, gender expression, marital status, national origin, ancestry, or tribal affiliation. So when the safety net was, the behavioral safety net was created pursuant to the statutes over the past few years, these were written in as these clear requirements that individuals cannot be refused care based on. So what this really means when we look at providers and how these providers fit into the system is that there's no wrong door, that individuals aren't turned away without appropriate care or coordination, and that triage includes referral to both other behavioral health providers that can meet the needs of an individual and also resources outside of the behavioral health system. It doesn't mean that providers are providing services outside their scope. And it doesn't mean that providers cannot refer an individual to more appropriate services through appropriate care coordination. So care coordination is this key obligation of the safety net system and these safety net providers, because it ensures that an individual isn't refused the care that they need or coordination to the care that they need. So safety net system competencies are also a key part of the requirements for both the essential and comprehensive providers. And some of these competencies that you see specifically within the Chapter 3 rules are proactively engaging priority populations throughout the care continuum, incorporating and demonstrating trauma-informed care practices throughout the care experience, promoting person-centered care and cultural and linguistic competence, utilizing evidence-based and evidence-informed programming to promote quality services, and competency and de-escalation techniques. So again, these come directly from statute, and the difference between what comes from statute and what we put in rule is the statute, we can't change in rule. So what we seek to do with some of these rules is to clarify how providers are supporting individuals and how they're meeting these requirements that have been created statutorily.
Erica, we're starting to get some questions in the chat. I wonder if now might be a good time to take a little pause.
Yes, great.
All right, so we had one question. So comprehensive providers don't have to do all of the items under essential providers like withdrawal management.
That is correct. As it's currently written, comprehensive providers are not required to provide withdrawal management, but they could.
Gotcha, thank you very much. We had another question about general question regarding refusal. What about people who have sex offenses? I know that there are some municipalities, cities, etc., who have strict rules around sex offenders. Is this a valid reason for refusal? I'm not sure we've had quite that question before. That might be one we need to do a little more digging through, but do you have anything, Erica?
Not straight off the top of my head. I think that where there's conflicting law, that would be certainly something that we would need to look into. But generally, that there is that specific requirement that folks are not turned away based on previous criminal and criminal justice involvement, which would also be applying here. So yeah, I think we might need to look into the specificity of that a little bit more.
Yeah, thanks. And our question asker, Bria, said, happy to keep us on our toes. So appreciate you bringing up those questions. And that's when I think we need to do a more complex situation that we need to do a little more research into how exactly that one would work. We have another question. Will geographic location be factored in when a provider refers to another provider?
That is a good question. I don't know that we have spoken directly to that in rule, and it's certainly something that we maybe need to consider. The expectation would be that if a provider is referring someone to an alternative provider, that would be a service that is accessible to that individual and appropriate for them. And so I think that's where there is graphic factors that need to be considered, referring someone across the state if there's no way to help them get there, and if that's not the absolutely only option, does not seem like the best care coordination. So Tom, also, if you want to add to that.
Thank you for the question, Megan. Erica, I think you're heading in exactly the right direction. I wonder if we pose some language and discuss internally about, though I think you said it exactly the right way, like factors that should be considered in terms of such a referral if the person in question is, say, outside the scope of the types of services that provider in question, so that a provider can't automatically fulfill its obligation by suggesting a provider that the person receiving services could, for instance, not possibly get to. So I think we need to come up with some phrases that will accomplish that, and appreciate you bringing it up, Megan.
Thanks for that. We had another couple of questions that are pretty related, but I will read both. How do comprehensive providers handle situations where a client might assault or threaten a staff person? And the similar question is regarding the no refusal of individuals who have exhibited aggressive behavior. What about when that individual has physically assaulted the provider or made credible threats against individual clinicians or facilities?
Yeah, thank you. These are conversations I think that we're actively having with hopefully all of you today, and also a number of different groups that we have been engaging with in our different forums. This is something that comes up a lot. And as I was saying, the that no refusal piece was written into law. When our legislators were establishing this system, they felt it was really important that that be included because it has been a gap in our system up to this point. And we recognize that safety of providers and clinicians and support staff in agencies supporting individuals across the state is also, of course, a really important consideration. And so I think in our conversations, we're trying to kind of figure out the right way to clarify clinical scope and some of those capacity and clinical expertise questions to identify when these behaviors, when an individual is expressing or demonstrating aggressive behaviors, when it's appropriate for a provider to be referring them to a higher acuity. I think especially the way it's written into the law, we're talking about these aggressive behaviors that do present as a result of behavioral health diagnoses. And so oftentimes it's actually a need for additional care and support for that individual. And so none of the no refusal requirements are meant to say that an individual can't be referred to a more appropriate level of care. And so I think that's one distinction that we are really trying to clarify within rule right now and are open to ongoing feedback and conversations about that. And then secondly, I'm just reading the questions again to make sure I'm not missing anything. Yes, and I'm seeing Megan's comment around medication. So I think those are the types of things that we're trying to figure out the nuance of, is when are we supporting someone through a transition that might be difficult when we know that that is a behavior that is going to resolve with appropriate care versus when is that setting no longer appropriate for that individual to be served in, and what are the next steps that that provider can take, referring them to an outside provider. Competency and de-escalation is one of those key competencies of the safety net system. And so also ensuring that these safety net providers are training their staff in appropriate intervention techniques to be able to de-escalate and hopefully keep people safe in situations where aggressive behaviors do present also. I know that's not like the full answer. I think that this is a really tricky one that we're trying to, engage with people with lived experience, with the providers, with advocates, and with all of you who fall into those categories and maybe more to figure out what a good solution here is, where we can stay true to the intent of the statute, which is that people aren't being refused care based on aggressive behaviors, and where we can factor in some of the clinical complexities here.
Thank you for that, Erica. We had one comment about med switch should be factored in here. Thank you for that feedback, Megan. And then another question that I can help address, will an RCO or a recovery community organization be eligible to be a comprehensive provider, or will they want to without being an RSSO or a recovery support services organization? So through statute, a comprehensive community behavioral health provider could be a licensed behavioral health entity or an approved behavioral health provider, which could include an RCO. But what I'm thinking through is that entire level, all those levels of service that are required to be provided by the comprehensive community behavioral health provider, just based on my understanding of services currently offered, probably would not be kind of fitting into that framework, as comprehensive includes a number of clinical services. And I think most RCOs are probably not providing a clinical level of service, or at least as kind of that RCO piece. So I think there's nothing that would prevent that from being the case, but I'm not sure that would be the exact right fit for an RCO.
Awesome. It looks like we maybe answered those questions. So I'll go ahead and continue, and we can pause in a couple minutes.
Hey, Victoria, this is Tanya. Can I ask really fast question?
Yeah.
Would that only be true then, because it says recovery supports, would that only be true for those who are providing clinical services under the comprehensive?
So I want to make sure I'm understanding the question. So are you asking, would RCOs as comprehensive providers have to provide clinical services?
No, just when I see recovery support on that list of comprehensive providers, is that more connected to the recovery support that happens in a clinical organization?
I understand what you're saying now, Tanya. Thank you so much for clarifying.
Sure.
So I think it could be a variety of things. So it could be in a clinical setting. Another situation that might come up is a comprehensive provider may contract out. So they may provide that recovery support themselves, which again, likely a clinical setting, but we also wrote the recovery supports chapter 6, which I know you're very familiar with. To be fairly broad of recovery support services. So it's not just within a clinical setting, that can be pretty broad. And a comprehensive provider could also potentially choose to contract out with, for example, an RCO to provide recovery supports, as long as they're meeting the requirements in that chapter 6. So it wouldn't just strictly be limited to recovery supports in a clinical setting. Does that help?
Yes, thank you very much.
Of course.
So I'm going to dive into this next slide. So care coordination, we've talked about that being a service that's required to be provided by both comprehensive and essential providers, in addition to whatever other services they are opting or required to provide. So when we talk about care coordination, this is really a spectrum of services that may be provided to an individual, dependent upon that individual's needs, their clinical acuity, what types of resources they already have and are connected to in the community. So when we're talking about these requirements, they're as needed for the individual. We understand that the individuals that are seeking care from safety net providers are incredibly diverse in their needs, resources, things like that. And so these are as applicable to that individual and the needs that they're presenting with. So care coordination is including things like conducting comprehensive assessments of that individual, facilitating access to needed resources and services based on those screened and assessed needs. So things like conducting application assistance, referrals, and form handoffs to get them to the services that they need, providing accessible and culturally meaningful resources and information, coordinating with partners that are trained to provide specialized services, risk stratification, discharge planning, transition planning, prior authorization, insurance appeal, and medication reconciliation, equipping the individual with information through means that are accessible and appropriate for the individual based on their needs and preferences. This is something that we've added that we're really trying to get at, that need to support individuals in the way that they are receptive to. And so what are those means of communication that are going to be effective for that individual? That's not something that we can necessarily decide at a population level. And so wanting to allow room for the specificity of that, for these to always be person-centered and person-specific services. And then also collaborating with other systems and entities providing care coordination services to the individual. I'll note too that we are making ongoing updates to this chapter as we are engaging with all of you. And one of the specific changes that we've made is clearly calling out own path here in these care coordination requirements. For those of you that are familiar, own path is one of the BHA's health information technology tools. It's a website that everyone can access. And right now it has a search function where you can search for currently licensed providers by the BHA, but over time that will be built out to include more providers and more services. And so we want to, we get that question a lot, is how are these things all connected? And some of them are still in process and being built out, but we're trying in rule to also provide room for the rules to grow alongside these systems that are also being built out here at the BHA. I'm checking to see. Okay, I'm not seeing care coordination specific questions, so I will keep going. The next section of chapter 3 is policies and procedures. So these policies and procedures, the requirements are that they're aligning, that the agency's policies and procedures in general are aligning with the safety net system competencies that we went over a couple slides ago. Specifically, we're requiring a policy on rights of individuals, and those specifics match chapter 2. So the same that we've called out for BHEs, but here requiring that also for safety net providers. And then personnel training requirements. And there are a couple key requirements that policy and procedure needs to be addressing, including de-escalation techniques, culturally and linguistically appropriate service delivery, and trauma-informed care and service delivery. Again, the goal here to really align with those system competencies. The next section that applies to essential and comprehensive providers is equity plans. Like all things that I'm talking about today, these are things that we are interested in gathering feedback on, and we're interested in working with you all to make these requirements work for providers, for the individuals receiving services. We're not trying to create additional burdens or boxes to check. We're really trying to drive towards better outcomes for the individuals receiving services through the behavioral health safety net system. So this is one way that we've envisioned doing that. And we're getting a lot of questions about this. So I imagine we'll get some today, and happy to continue to talk through how to make this really make sense. So equity plans are designed to be part of the agency's quality management program, and their goal is to improve treatment access and outcomes for priority populations as identified by the BHA. And when I say as identified by the BHA there, that's because the definition of priority population is defined within House Bill 22-1278. And it specifically talks about how the BHA is going to use data to define these in ways that make sense for the state as a whole and regionally, knowing that sometimes we see different needs in different pockets of our very diverse state. So an equity plan would require the development, implementation, and evaluation, including to include collection and analysis of data to evaluate equitable outcomes for priority populations. The plan goals and outcome measures should be identified in conjunction with individuals, families, and advocates who represent the identified priority populations. And like I said, we're actively working with you all as stakeholders on these rules, and just wanted to point out that we're currently clarifying in rule that this should be a targeted goal relevant for the agency. So it does not need to address all priority populations. We're not saying that someone needs to develop a unique plan for every single priority population. This is really a plan that makes sense for the population that the provider may be serving, and developing a targeted goal for that period of time. The next section is culturally and linguistically appropriate services. These requirements have been written to align with federal culturally and linguistically appropriate service requirements. And agencies are responsible to train their staff on interpretation and translation services that are available to individuals and families. And it should include training staff on the procedures and how to access and use those services. I will pause there. So what I've gone over up to this point is those requirements that apply to all behavioral health safety net providers, so essential and comprehensive. And then we'll dive into some of the specifics of essential versus comprehensive. So I'll just give a second for questions.
Yeah, and we've got a couple in the chat. And so Natasha asked, aggressive behavior resulting in the shortage of access to certain behavioral medications, is that factored in here as well? I'm wondering, Natasha, if you could clarify a little bit. I'm not sure I'm quite following the question. If you would feel comfortable coming off mute or just providing a little more detail there, I think we can take a look at that. And then a question from Megan, will de-escalation still include restraints in isolation?
I see Natasha coming off mute, so we'll start there.
Great.
My name's Tasha Conker. What I'm getting at, is it covered like under the continuum of care? Because as somebody with lived experience, certain behavioral health medications there has been a shortage of, and the on again, off again has created aggressive behavior and also regression of some mental health with my diagnoses. And then it's affecting my housing. Like because of the continuum of care, and I got the housing portion of that. And during a time period, I was threatened to lose my housing. Is that like covered in there? Like how they're not, I don't know how they're supposed to handle that under the continuum of care.
Yeah, thank you so much, Tasha, for sharing and for asking that question. I think that there are elements of that we are able to kind of speak to within our rules, and then some pieces that are a little bit outside of our scope. So sometimes availability of medication, is totally separate from the providers prescribing that and things like that. A couple of rules that we have added in specifically for comprehensive providers to try to address, I think, some related issues. One is that if an individual who has been receiving care through that comprehensive provider shows up and they've maybe run out of medication because they missed their last visit or something like that, we're requiring that within 1 day, that individual is able to be seen and receive those urgent services. So ensuring that you can get your prescription if you've run out. That doesn't necessarily guarantee that the pharmacy had that medication specifically. And so that is hopefully, being addressed between the pharmacy and the prescriber, that they would kind of communicate there and find an alternative medication that you could get access to. But that's one of the things that we've built in on our end, is recognizing that sometimes when an individual is in a behavioral health crisis or navigating losing housing or, any number of things, that they miss an appointment and then they're out of meds. And then that can, like you're saying, result in some of these behaviors because you aren't getting access to that care that you need. So that's one way that we're trying to address that in rule.
Thank you for that clarification, Tasha, and apologize for cutting you off. I'm doing the recording, and so I can't see all people on this call. So I appreciate you coming off mute and providing that clarification. And thanks, Erica, for your response. Next question we had was around the de-escalation, and does that include restraints and isolation or seclusion?
Yeah, so that is a good question. Yes, it does. There are rules around what is appropriate use of restraint and seclusion within Chapter 2 for licensed facilities, for designated facilities, extensive rules in 2765. I'm not the expert on that. And so if we need to dive into that conversation, we have multiple other meetings scheduled upcoming that we can definitely talk more about that. So yes, but always as those rules in both of those places really specify that restraint and seclusion are the last resort. And we would want alignment there. Training into de-escalation techniques should certainly be many interventions that providers are trained on and staff are trained on prior to implementing things like restraint and seclusion. And I see Tom's hand up.
Thanks, Erica. First, I agree with your assessment of that. And so my comment is less about the specificity in rule about use of restraint and or seclusion, and more about that when we talk about this in terms of a safety net provider, I want people to be thinking about if they're going to provide that type of service, then they would need to operate in conformity with those sections of rule, which cover, and this is the part that Erica was talking about, cover the requirements about restraint and seclusion. So I just want to make sure that people aren't thinking about restraint seclusion, looking in chapter 3 or chapter 4 and thinking, well, there's no protections for restraint seclusion, because we have to look back at our other chapters for that. So really just a orienting type of comment about where to find it.
Thank you for that. But another question that I think we might be covering later in the presentation, but I'll defer to you, Erica, about what makes the most sense. With regards to care coordination, can you expand on what is meant by conducting comprehensive assessments and what would be needed and required?
Yes, thank you for that question. So when we are talking about comprehensive assessments here, they are in line with service plan requirements for different provider types. So depending on the services, different requirements do exist for what those service plan what those service plans look like. Outpatient is going to look a little different than residential. And when we're talking about care coordination, those requirements that are being built in, and the rule itself is more specific than that slide. So thank you for asking this question. Some of those requirements are developing or conducting comprehensive assessments to develop and support person and family-centered service plans that promote integrated whole person health across the spectrum of health services. So things that we're talking about that are specifically listed in rule and would be as applicable to those individuals would be things like addressing access to high quality acute and chronic physical and behavioral health care, peer support networks, social services, housing, educational systems, and employment opportunities. And I think to your question, I think you raise a good point that when we use the term assessment, it's not always clear what we're talking about. And so we're actively having conversations too about how we can ensure that the terms that we're using are clear and not creating confusion, that they mean one thing here and one thing somewhere else. So we're trying to kind of clarify within these rules how those screening processes work so that providers are identifying those needs that fall into some of those categories that I was just mentioning, like access to healthcare, housing, food stability, things like that. And then what we're really requiring is that there's a plan in place that's identifying what are those individuals' goals around needs that have been assessed or needs that have been identified. And then how is that provider through care coordination supporting that individual to reach that goal? So is that connecting them to other services? Is that actually directly related to some of the behavioral health services that they're receiving from that provider? Things like that. Feel free also, I think, Adam, you dropped that into the chat. So if you want to add any comments or come off mute and request any clarification, happy to continue that part of the conversation.
Yeah, if I can jump off mute for a second. Yeah, I was more thinking like, is it going to be like a standard set of questions and requirements is more kind of where I'm going. And yeah, and like you were saying, I think it depends on the level of care that they're receiving. But say, you know, they kind of go with integrated kind of care. So obviously, you know, working at facilities that have integrated types of care, what does that exactly look like and mean for those types of facilities is more kind of where I'm going for it.
Yeah, thank you so much for that. We were actually having conversations this week with some other integrated care providers to kind of discuss this exact topic. And specifically around integrated care, our goal is not to require a provider who's providing integrated care to duplicate screenings and assessments that have already been conducted, maybe on the more medical side of the integrated care provision, but really ensuring that we're identifying some of those health-related social needs for that individual and then developing care plans based on that, or service plans, excuse me.
Great. That's helpful. Thank you.
All right. Give folks a sec to raise their hands or come off mute, and then we'll dive into essential behavioral health safety net providers. Okay. So I went over this at the beginning, but just to recap, so when we're talking about the services provided by a behavioral health safety net provider, we're talking about care coordination and at least one of the following. So emergency and crisis services, which includes a couple of those sub-endorsements like walk-in crisis or CSUs, ATUs. A provider doesn't need to be providing all of them. It would just be one of those services. Outpatient, intensive outpatient, residential, withdrawal management, which has now been integrated into the continuum. So you'll actually see those withdrawal management requirements built into our outpatient and residential chapters 7 and 8. Inpatient care, integrated care, and hospital alternatives. And I will just point out here that these aren't all services that we are directly endorsing. There's not an inpatient chapter in our rule volume. And that's because when we're talking about essential behavioral health or essential safety net providers, those are sometimes providers that are licensed by other state departments or providing services that fall outside of BHA licensure and the settings that we are licensing, but they are providing those critical behavioral health services, and so they can be approved as part of the safety net system. So we're not creating an endorsement for inpatient services. There are other rules for that, but if those providers are opting into the behavioral health safety net system, they are meeting these Chapter 3 requirements as part of that approval. So we've talked a little bit about priority populations, but just this is a long definition, but I wanted to review it here. So the way that priority populations is defined is it means people who are uninsured, underinsured, Medicaid eligible, publicly insured, or whose income is below thresholds established by the BHA, and presenting with acute or chronic behavioral health needs, including but not limited to individuals who have been determined incompetent to stand trial, adults with serious mental illness, and children and youth with serious emotional disturbance. And then I mentioned this earlier, the bill allows for the BHA to identify other populations that are underserved that meet those above criteria and might require specific prioritization on a regional or statewide basis based on health equity data. So that could be including but not limited to people experiencing or at risk of homelessness, children and youth at risk of out-of-home placement and their parents, people involved with the criminal or juvenile justice system, people of color, American Indians, Alaska Natives, veterans, people who are pregnant, people who are lesbian, gay, bisexual, transgender, or queer or questioning, and individuals with disabilities as defined by the Federal Americans with Disabilities Act. So it's a long list, but the idea is that the BHA is using that health equity data to really identify what those underserved populations are regionally or statewide, and ensuring that services are being provided to those individuals. And that's an important definition when we're talking about essential behavioral health safety net providers, because essential behavioral health safety net providers need to serve all priority populations unless they're approved to serve a subset of specific populations. So we know that there are providers out there that exist with really specific missions to serve some of these populations specifically. And so the goal is not to have them now have to broaden and serve everyone. They can continue to serve those priority populations that they have expertise to do, to serve, and be approved to just serve that subset of priority populations. Once it's established what populations that provider is serving, that provider should have personnel with the appropriate expertise to serve individuals who are part of the identified priority populations and or are identified within the no refusal requirements. And then if providing outpatient services, essential providers must be designated to provide services to patients on involuntary outpatient certifications, and they should also be offering clinical services during night and weekend hours. And those requirements are really built in because the essential behavioral health safety net providers are really receiving these enhanced payments in order to be serving or to be meeting some specific needs in the community. And those are a few of those identified needs. Triage and care coordination. So based on those priority populations, based on that subset that the individual would be receiving, or excuse me, based on that subset of populations that provider would be serving, when an individual presents for care to an essential provider, providers have the responsibility to screen and triage all individuals who are attempting to access services, and that they are doing so to create a system where there is no wrong door. The standard criteria for determining when an individual will receive care coordination to facilitate a transition to an alternative provider instead of being seen by that provider are the following. So the individual's presenting problem or diagnoses are outside the scope of practice of the provider, including things like the age range with which the provider works, which would be approved in those priority population subsets that they're serving, or modalities and intervention they've trained in. So it's like specifically including that exception for priority populations the agency is not contracted to serve. The individual presents with a need for a level of care the provider is not endorsed or designated to provide. So if an individual presents to an outpatient clinic and they're needing a crisis level of care, that provider is able to support that individual in accessing that crisis level service. That's not refusing the individual or turning them away. It's supporting them with appropriate care coordination to access the care that they need. And then the final criteria would be that the provider cannot provide services within an appropriate time frame per the individual's needs and the provider's capacity. And so when we're looking here, that's based on the assessment of a clinician, the screened needs of that individual. If they are presenting with an acuity where they're needing services really urgently and that provider wouldn't be able to provide that, then that provider would be able to refer that person along to a provider that could serve them within a more appropriate time frame. A really clear example of this would be if an individual is referred to a residential provider and there aren't beds in that facility, then they would be appropriately able to support that individual in accessing different services because that residential facility would not have the capacity to serve that individual at the time. So the provider will use those standard criteria to determine whether an individual will be served by the provider or if care coordination will be provided to connect the individual to the correct services. These processes do apply both when an individual presents for care initially and if an individual's needs change during an episode of care. So we understand that sometimes someone presents with a different acuity, they're being seen for a period of time, and then their needs may dramatically change. And these same criteria are to be used to determine if that essential provider can transition that individual to a different level of care. One of the requirements of the bill is that data on referrals made per this part are being tracked, and that should include things like individual demographics, standardized descriptions of the needs of the individual that could not be met and require the individual to be referred to another provider, and the outcome and timeliness of the referral. So I will pause there because I think that this is normally where we get some questions.
So we do have a few questions, but not specific to the piece that you've been presenting. Would you like to hold those or take those now?
I'll let you decide based on what you're seeing.
All right, great. I think, yeah, we might just pause right now and take a few of these. So Elizabeth asked, when you say that walk-in centers are included in emergency and crisis, does the same requirements apply to the other crisis services such as crisis stabilization units, CSUs, and respite under Colorado crisis services? I just have a clarifying question about that, Elizabeth. So are you asking if if there are those endorsement requirements, or are you thinking about these safety net requirements in Chapter 3?
Yes, I'm actually thinking about Chapter 3. So you had said that if people show up at any provider office with emergency and crisis issues under the essential behavioral health safety net provider, When I think of emergency and crisis, I'm thinking, are you just referring to the walk-in center? What if the person also is receiving mobile crisis or is admitted to crisis stabilization unit or admitted to respite? Does that also fall under these requirements? Because a lot of those essential providers could also be providing those additional levels of care.
I think I understand sorry.
Yeah, I was gonna say, if this doesn't fit for what you're talking about here, it's fine. Just let me know. Maybe I'm asking the wrong question for the wrong chapter.
Let me try to answer, and if I'm not getting there, I'll see if any of my team members can jump in, or we can certainly touch base offline as well. So my understanding of the question that you're asking is, if an essential provider is providing these different types of crisis services, are all of the same requirements applying? Is that the question?
Yes, that is correct. Yes.
Okay. So yes, in terms of the overarching requirements that I've gone over in terms of no refusal and some of those things are all applying regardless of which crisis service that provider is providing, if they've opted to become part of the behavioral health safety net and been approved as an essential provider. That said, the distinctions between those services still exist. And so a walk-in crisis center is providing a different level of care and has a different capacity to serve the individual than a CSU or an ATU, for example. And so supporting someone through care coordination to access a different level of crisis service would be appropriate and in line with the requirements of the safety net provider. But no, we wouldn't be asking them to all be providing those exact same services.
Got it. Thank you.
Thanks for that. We had another question about the definition of underinsured. So I'm not sure we have on our side a specific definition handy, but I believe that's something our partners at Healthcare Policy and Financing probably have a specific definition on. So I think that's one that we want to check with our state partners to see understanding. I think we all understand that concept of being underinsured, but I'm not sure we have a specific definition as far as what, if there are exact numbers involved or exact definitions there. So I think that's one that we may have to do a little homework with our state partners, and then if appropriate may incorporate a definition into our regulations if that feels appropriate. So thank you for that question, Edie. Had another question about, will there be oversight that is sufficient for these regulations? So I can speak a little bit to that, and then Erica and Tom, if you want to add anything. So our rule drafting team, our safety net licensing managers that you see presenting these regulations will be transitioning into being safety net oversight. So we will have within quality and standards licensing managers who are monitoring, who are providing oversight related to these safety net provider regulations, so that we can then issue that approval, and that approval can be used to participate in the safety net system. Anything else any of my team would add for that?
I can add additional detail, but if that answered the question, we don't have to belabor that particular point. Megan, anything else?
Not at this moment. Thank you, Tom. I will probably follow up with you at a later date. Thank you.
Sure thing. All right. Thank you.
Thanks. I did see one other just comment related to underinsured, including the Division of Insurance. Yes, thank you, Lori. Other state partners that are very important to include in this conversation, and get what their kind of working definition of that underinsured term means. I see another question. I know historically the priority populations of getting people into treatment has been pregnant parenting people and IV drug users. is the list of priority populations, this new list that Erica was reviewing, now replacing the few populations that have been the priority in the past. One thing I want to note here is this priority populations that I see Tanya's talking about, the pregnant parenting and IV drug users, is specific to our block grant, our federal block grant in funding treatment. And I think that, I'm not sure if Ryan has any additional insight right now, but I'm thinking that we need to figure out how that block grant funding priority populations intersects with this new safety net priority populations definition. I'm not sure if we have an exact idea of that at this point, but I would defer to Ryan or any other team members if there's additional insight you can provide about that question.
Yeah, thanks, Victoria, and good question, Tanya. Yes, with our block grant dollars, there's certain allocations with federally identified populations that have to get funded through our block grant application and funding model. So those are all still requirements for us to meet through block grant allocations. So those do not, or this list does not replace those, as if we want to continue to maintain block grant funding, we'll have to meet those federally required lists as well. So yep, and Tanya, we can talk offline a little bit too, because yeah, we got some block grant recommendations coming from BPAC shortly as well.
Thanks, Ryan. Got a lot going on. We have a question here. Will the data on referrals that need to be tracked be required to be put into a network or database developed by the BHA, or can that be captured by safety net providers in patient charts? Does anyone on the team want to take that one?
It's a good question. I don't know if Tom or Ryan have a more comprehensive answer here. I think the way that we've written into rule right now is that would need to be information that you could provide to the BHA in kind of a single report. And so if that is something that your medical record could pull, then that would be sufficient the way that we've envisioned it currently for essential providers specifically.
I just say I agree with that interpretation.
It looks like we've got one more question that I'll pose, and then we can continue on. So for the comprehensive community behavioral health provider portion, is IOP, or intensive outpatient services, try to translate acronyms where I can, included in this expectation?
Yes, thank you for the question. IOP, or intensive outpatient services, are included. As you may have seen in our current rule drafts, we did combine what were previously two separate chapters of outpatient and intensive outpatient into one chapter that kind of captures that full outpatient continuum. But the requirement for comprehensive providers would be to have sub-endorsements for both outpatient and intensive outpatient. I'll note it is not your question, but it's a question we get. There's been questions around whether MIP services that are also part of that chapter are required. And the answer there is no, a comprehensive provider is not required to be sub-endorsed and providing MIP services or minor in possession services.
Thanks for that, Erica. I think we're all caught up on the chat, so we can keep going.
Awesome. So there are some governance requirements. Again, these are coming straight from the statute that created the essential behavioral health safety net providers, but overall responsibility for the administration of an essential provider must be vested in a director who is an authorized practitioner or licensee. I use those terms and I don't have the definitions on this slide, but those are terms that have been defined in chapter 1 and generally are encompassing authorized practitioners. Those are our MDs, our advanced practice nurse practice, APRNs, advanced practice registered nurse, TAs, physician assistants, those types of providers. And then licensees are more of our behavioral health specific licensed providers. So licensed professional counselors, licensed social workers, those types of providers. The full list can be found in Chapter 1. If the director is not one of those, the agency would need to employ or contract with at least one of those, an authorized practitioner or a licensee, to advise the director on clinical decisions. So there is that requirement for clinical oversight here. Each essential behavioral health safety net provider shall also be under the control and direction of a county or local board of health, a board of directors or board of trustees, a for-profit or nonprofit organization, a regional mental health board, or a political subdivision of the state, be free of conflicts of interest, and enter into a contract developed pursuant to Section 2750-203 and accept publicly funded individuals. And that statutory reference is the universal contracting provisions that are currently being developed. All right, so I stopped one slide short of comprehensive providers, but those governance requirements come straight from statute. And if we get questions, I'm happy to revisit those later, but I'll just dive into comprehensive providers. So comprehensive community behavioral health providers are a second type of behavioral health safety net provider. And like I mentioned earlier, they're providing care coordination and all of the following services, either directly or through contract. And those services are emergency and crisis, outpatient, intensive outpatient, recovery supports, care management, outreach, education and engagement, and outpatient competency restoration. So those providers are providing all of the safety net services I just mentioned. They're serving all priority populations that we talked about that definition. And they have personnel with appropriate training and expertise to serve those priority populations and comply with the non-refusal requirements that we've been talking about. Some outpatient specific requirements for these providers. Outpatient clinical services should be provided during times that ensure accessibility and meet the needs of the individual population to be served, including night and weekend hours. Providing services at locations that ensure accessibility and meet the needs of the populations to be served, which includes utilizing mobile, in-home, and telehealth services. And then these providers must be designated for 2765 involuntary outpatient certifications. I am seeing Elizabeth's question of nights. I think that is something that we are certainly accepting feedback on around what should these requirements be. We've also received feedback that some of these requirements may be different in different parts of the state where the populations served are different. And so at this point that has been left broad, and we're certainly open to receiving feedback on what would be an appropriate requirement for these comprehensive providers to ensure that they are meeting the needs of the individuals that they are serving. All right. A couple more outpatient specific requirements for comprehensive providers. If an established individual, and when we say established, we're talking about an individual that's actively receiving services from that provider, presents with an emergency or crisis need, appropriate action is taken immediately, including any necessary subsequent outpatient follow-up. So getting them to the appropriate level of crisis services and then ensuring that that follow-up is happening on an outpatient basis. And if an established individual presents with an urgent need, clinical services, including medication management, are provided within 1 business day of the time the request is made. And that was what I was referencing earlier when I was answering Tasha's question, but this is where that lives. So for crisis specific requirements, services are available and accessible 24 hours a day. Available services should include walk-in crisis services, CSUs or ATUs, mobile crisis and respite care services. And then there's a requirement that the agency maintain a working relationship with local emergency departments And for individuals actively receiving treatment from a comprehensive community behavioral health provider, there should be protocols in place for staff to address the needs of individuals who present to a local emergency department in a psychiatric crisis. We have specified there that that's when the comprehensive provider has been notified of that admission. We understand that with the current health information technology infrastructure, that those notifications are not always automatic or made. And so we are not trying to set folks up for failure here, but we do want these systems to be working together and for those behavioral health needs to really be supported by those comprehensive providers. So screening, triage, and care coordination for comprehensive providers looks pretty similar to what we talked through with essential providers. One of the major differences is that comprehensive providers are required to serve all priority populations. So there isn't that caveat that they have a contract that can specify a subset of those populations. So the criteria for determining whether the individual is outside the scope or capacity of the provider are the same with that exception. So the individual's presenting problem or diagnoses are outside the scope of practice of the provider, including age range, all the same language we talked about. And actually, I'm realizing that that's incorrect because age range, I think we are talking about serving youth in these settings, and so that should be removed. And I will make sure that that is correct in rule. I might have just copied the slide wrong. And actually, I did copy the slide wrong because it also talks about the priority population. So I apologize. This was duplicated from the essential provider side. So when we're talking about comprehensive providers, it would just be that individuals are presenting problem or diagnosis are outside of the scope of practice of the provider. And that would really be meaning level of care. So the individual is presenting with a need for a level of care the provider is not endorsed or designated to provide, and the provider cannot provide services within an appropriate time frame for the individual's needs and the provider's capacity. And this applies to the scope of the agency as a whole. So referring someone from outpatient services to a more acute level of care is again within the scope of these requirements. That wouldn't be considered refusing the individual. So when we're looking at how a comprehensive provider is applying these criteria, it's really looking at the scope of all of the services they're providing and determining if that individual, where they fit in that. If a priority populations and priority population individuals' needs exceed the treatment capacity or clinical expertise of the agency has to ensure that the individual has access to interim behavioral health services until the individual is connected to the most appropriate provider for ongoing care. And the comprehensive provider needs to obtain approval from the BHA or its designee. And for Medicaid members, it would be the RAE prior to referring an individual to alternative services. So this is where the statute really does create a pretty significant distinction between essential and comprehensive providers, whereas essential providers are applying this criteria and referring folks on to the next provider using appropriate care coordination. With comprehensive providers, the statute specifies that an individual cannot be turned away unless that has been approved by the BHA or the designee or the RAE. The one exception to that, and it is clearly written into the rule, would be a crisis setting. Or a crisis situation, excuse me. And so if that provider truly could not provide services that were needed by an individual in crisis due to capacity at the time, that individual could be referred to an alternative provider, and that would not need to wait for pre-approval. I am seeing lots of questions come in, so I will go ahead and pause. Victoria, you want to guide me?
Sure, of course. So let's see. I see a question about how long will it take to receive approval. So one thing I'll mention is that this approval process will not be available until January 1st of 2024, that is when the approval, these rules will become effective, pending approval from the State Board of Human Services. So that is when we will be able to start accepting applications. That said, this is a brand new program, and so I'm not sure I could put an exact time frame on how long it will take to turn that around, just because this is a new process for us, and we'll be working through getting those approval applications through the process. So I think it's a priority for us to do that in an efficient manner, but I'm not sure I could give an exact time estimate at this point, just because that's a very new process for all of us. Another question about CSU or ATU, verify that it is an or and that ATU is not required. Thinking back to the slide, I'm guessing that was regarding for comprehensive safety net providers. Not all providers can offer an ATU, some can offer a CSU, but not an ATU.
Yes, thank you. And I'll kind of answer Edie's question at the same time. These are conversations that we're actively having with, as we finalize these rules, is what should those crisis requirements be? So right now it's kind of that 24/7 access, and we have specified that should include those specific subset of services. And we are very actively engaged in conversations to really determine what makes sense. Like you point out, does it make sense to make a statewide requirement, or does this need to be more regionalized, which wouldn't necessarily live in rule, but rather maybe some of the contracts, and how our BHA is going to play into this. So there's a lot of factors here. I'm seeing from Barbara specifically the concern around CSU or ATU. I think we have for sure decided that that would be an or, not an and, even if we were requiring multiple services to be provided, multiple of those crisis services to be provided, it would be a CSU or an ATU and not both. Does anyone else on my team want to add anything there?
I would just say I do think that's the current state of our discussions. I think there's also corresponding concern from other groups in Colorado that may not be services sufficient, specifically if we are saying that there are two different levels. People may recall in a more crisis specific stakeholder meeting, we talked about not having that level of specificity and rule, and saying that the agency which is endorsed to provide crisis services wouldn't necessarily need to create levels between CSU and ATU. And the strong feedback we got from the provider community is that they very much wanted our rules to be specific and create the delineation. So with that as background and being said, some of the feedback we've gotten is, hey, if we're being expansive enough to say the provider can do CSU or ATU, and if ATU is a higher level of care and a comprehensive provider can choose between the two, that may not serve everyone in that particular location, and it could be particularly problematic in a rural area where folks wouldn't have anywhere else to seek services. So I realize that's sort of the converse of maybe what Edie's driving at in her related question. So I just say our current state is it's an or. We do have that question in particular from some of the advocacy communities, so we continue to mull that over. With regard to other options for this comprehensive provider, we are saying that a comprehensive provider can fulfill its obligations by subcontracting with another provider to do that particular service type. So we will look at that in terms of considering application for comprehensive providers. So I hope it gets to that portion of the question, Edie.
And I see based on a few subsequent chats that I may have misunderstood the approval question. It looks like Edie's also speaking about prior authorization timeframe. So I had interpreted that approval timeline question as how long will it take for the BHA to process a safety net approval application? But it seems like the question really might have been around payment approval or payment authorization. If someone could let me know if I misinterpreted it in that way, that might be helpful. And then I saw another question around IOP. I want to make sure I understand if a patient is in the priority population and are unable to pay for IOP services, it is our responsibility to cover these costs as a facility. Anyone on the BHA team want to address that? And Edie, I see your raised hand. I think we'll take this one and then appreciate you coming off mute and explaining your question.
I can respond to the question around IOP. So this has been raised just this week around what's the difference between not refusing someone because they can't pay and then someone who's unwilling to pay and the difference there. So I think we're trying to figure out the specificity there. But I think specifically it would be some of those steps that you could be taking as a provider would be by providing care coordination, connecting that individual if they haven't applied for Medicaid and things like that to see if they can get that service covered. And then I don't know if maybe Tom or Ryan wants to speak to anything else specifically around that question of payment.
Oh, to make sure, Erica, you're talking about the commercial insurers question from Edie.
No, Daphne's question around if a patient is in a priority population and unable to pay for IOP services, is it our responsibility to cover these costs as a facility?
So I believe the rules says, I was thinking about something else when you were answering, Erica. I hope this is not duplicative. If I recall correctly, the rule is specific that it says that the facility in question should have a policy about people seeking services that do not have an ability to pay. And so the facility must have are you coming off to tell me you already covered that?
No, comprehensive providers do specifically have that requirement. We don't have it for essential. So there's just the non-refusal requirement around you can't refuse someone based on their ability to pay. So I don't know if there's any more specificity we can offer around that.
No, that was essentially what I was driving at. So Daphne, we may have to get back to you about that part.
And now I believe Edie raised her hand to help us understand your question. If you're still available, Edie.
I am. Thank you, Victoria. So my question was specific to the second bullet on this slide, that you need prior authorization from the RAE or BHA or whomever before referring somebody out for care coordination. Now, it's a long time since I worked in the commercial insurance field, and we weren't subject to prior auth requirements for care coordination, but certainly for other services. You know, you refer to somebody to a specialist, and that's got to be approved by the carrier within a certain period of time. And in these situations, you know, particularly if we're thinking about it in a triage context and you're referring somebody out right away for that crisis service or something else that you can't provide, but you need to first get authorization from the RAE or the BASO or whomever for it. I'm hoping that for the sake of the patient, they'll be subject to a pretty tight turnaround timeline for approving that authorization. Does that make sense?
Right. But I want to make sure we're talking about the same thing. So specifically not prior authorization for any kind of insurance payment. This is really more specific to care coordination in terms of, I see you nodding, so I think we're talking about the same thing.
Exactly, talking about the same thing, leaving the payment aside, just so I can make sure this client is getting the care and services they need. If I have to, pick up the phone and call the bosso to ask them for it, I really want to make sure that they're going to tell me ASAP, okay, we're cool with you doing this.
Right. And if we're asking you to work 24/7, the bosso or the Ray or us, we should work 24/7. And that's exactly the conversation we're having, that if people need services and the facility in question can't do it, for instance, if it's out of scope, and we're telling you, you have to check with us or the Ray or somebody first, then that shouldn't place a burden on the provider. And most importantly, it shouldn't place a burden on the person who needs the services right then and there. That's why they showed up. We don't have that figured out yet. That's one of the reasons we delayed the BOSO implementation to 2025, because of really hard questions like that. And I'll be transparent, we don't know whether we're going to house that particular staff and house that particular staffing requirement directly within the BHA, or if that's something we say to the BOSOs, you have to do that. And then I think there's really the larger question of how BOSOs in particular work with Rays. We recognize now we didn't do enough exploration work about what the Rays do, what we were talking about doing, and that our circles were overlapping a lot, and we need to stop that. And and this is really getting nuanced, and it is certainly a ever-evolving conversation, but that if we're wanting to exert our authority through the BHA, and perhaps I should say it, we believe the bill that created the BHA requires us to do so, then maybe there's some functions that the Rays are currently doing that we should talk about. Does the BHA assume some of that kind of work? Not, and most importantly here, not layer that on top of one another just to create burden and additional confusion. That's just some of the detail in terms of, yes, I 100% hear the call of the question here, and that's a problem we have to solve. And I think we solve that by having all of those nuanced conversations. We'll keep testing out our answers with you, Edie. She was trying to disappear, and then I made her come back.
All right, I think looking at where we are on time, I think let's keep moving. So Erica, I'll go back to you.
All right. So just a quick note around those referrals, if the comprehensive provider is referring someone to a different provider, if they've been approved to do so. And again, that would be referring someone who is within their scope or that they're requesting through the Ray or BOSO or BHA to pass or to transfer along to a different provider. That would be that they're recording individual demographics, standardized description of needs, and outcome and timeliness of the referral, same as the essential providers were documenting. Governance looks really similar, with one addition here, that the board and control and direction of the comprehensive community behavioral health provider must include voting members that have lived experience with mental health disorders and substance use disorders, and parents of children with mental health disorders and substance use disorders. And this is part of those statutory reviews. This came up a second ago, but there is a requirement that comprehensive providers do have policies on waiving charges and charging for services on a sliding scale based on income, and requiring that the provider not restrict access or services because of an individual's financial limitations. And they have to have policies and procedures describing eligibility for and implementation of those sliding fee discounts. And then policies are applied equally to all individuals seeking services. So the approval process is similar to a licensing procedure in terms of how it begins. When we're talking about approving these providers, they will submit an initial application to us at the BHA. That approval is going to be predicated upon evidence of applicable licensure or certification. So that could be if they have to be a BHE, they have their BHE license with the BHA. If they have to be an FQHC, that they have that federal certification. For smaller providers, maybe IPN providers that might be opting to become essential behavioral health safety net providers that aren't required to be BHEs, that could be a DORA license that they're demonstrating evidence of. And then they would demonstrate compliance with Chapter 3 requirements for safety net providers and demonstrate that they're providing services in compliance with the endorsement requirements. So for those specific services they're providing. Eligibility for HCPF enhanced payments is dependent upon, but not guaranteed by BHA approval. So just clarifying that those are two separate things that we approve and then HCPF is managing those payments. Okay, so the remainder of the chapter, I'm not going to go into too much detail about, but I'm happy to accept any questions, or if you want to email me, we have our rules inbox open if any of this needs to be further clarified, but there are two remaining sections, 3.7 and 3.8. 3.7 is the approval procedure, so it goes over that initial approval process that I was just reviewing. It also talks about provisional approval. So if someone isn't meeting all of the standards of the approval, how we work with them to get them to a full approval. Renewals, changes of ownership, rule waivers apply here the way that they do with licensure. So there's a process for that. And then what are those continuing obligations and our BHA oversight. And then for 3.8, enforcement and adverse actions, there are procedures for denial, revocation, and intermediate restrictions on an approval. And then, of course, that right to appeal, which always applies in these instances. So if we were to take enforcement or adverse action, the procedures a provider could follow if they disagreed with those determinations. So I will pause for any more questions about this. We do still have chapter 4 that we haven't gotten to. Lots of great questions on this chapter. So yeah, just be mindful. I want to be mindful of getting through that content as well if people would like to move forward.
Yeah, what I'm thinking, Erica, is I think this has been great getting all of these questions and being able to answer them live. I think maybe we move forward with you reviewing the content, and then the rest of the BHA team can look at the chat and answer questions in the chat as we're able, so that we can get through the content. How does that sound, Erica?
Sounds good to me. All right, care management is also much shorter. So this chapter is about 5 pages compared to 40. So this chapter, again, is applying only to comprehensive community behavioral health providers that are providing these care management services. And I provided that background earlier of kind of where care management fits as this additional service that comprehensive providers are providing. It's really seen as a service that kind of accompanies care coordination. So care coordination is being provided by essential and comprehensive providers across the board. And this is for those individuals that are presenting with the highest level of need, maybe involved in multiple systems, and so requiring just more complexity around the supports to navigate those systems and get connected to the right care. So the definition of care management is that it's an intensive level of support to address the complex needs of individuals, requiring multiple partners across sectors to work together as a team with the individual and family. Care management requires delivery of care coordination services at a higher frequency or for a greater length of time, in addition to outreach and engagement with the person and team to build necessary trust and support. So some of the specific requirements of these services are convening the team involved in the individual's care across systems for those with multiple systems involvement, connecting individuals to services needed to achieve whole person health. So a lot of those care coordination requirements, like I said, do apply here. And just to highlight those again, things like housing supports, making sure they're accessing physical health care, things like that. Risk assessment and mitigation through service planning is a huge part of care management. So identifying what those individuals' needs are, where they may present with the highest risk, and then creating service plans that are person-centered and aligned with the individual's goals to mitigate those risks. Supporting during care transition. So there's a section that kind of talks about if an individual is transitioning from a different level of care, what the requirements of the comprehensive provider are in terms of supporting that, making sure that individual stays engaged in services through that transition. So if they've, for example, been hospitalized, outreach to ensure that they're going to continue to show up to follow-up appointments or to support them in showing up to, if they are willing to continue to engage. Of course, the personal choice does play in here, and we do get that question. So supporting those care transitions, making sure medications are consistent through transitions, things like that. And then care management, like I said, is building upon those care coordination requirements. Part 4.4 and 4.5 outline frequency and documentation. So we have added in, not for care coordination, but for care management here, some specific or minimum requirements, given these individuals are receiving the service because of their level of acuity and the complexity of their needs. And so those minimum requirements right now are defined as 2 contacts per month, 2 face-to-face contacts per year, 2 multidisciplinary team meetings per year, and team meetings when there's rising risk or changes to the care plan. These are minimums, and so certainly these should be based on and responsive to the individual's needs. And then information sharing, there is no frequency. It should be taking place on an ongoing basis with the team. When we talk about personnel and training, there's a few requirements in this chapter, and really the goal is that the training is specific to the particular needs of the population served by the personnel, including the provision of person-centered, trauma-informed, harm reduction-focused, physically and programmatically accessible, and culturally and linguistically appropriate services. And we recognize that care management is a team effort, which is why there aren't necessarily specific personnel that we've identified as providing these services or specific licenses or certifications that those personnel may have. There may be tasks involved in care management that do need to be fulfilled by a clinician within their scope. There may be tasks that are appropriate for unlicensed staff with appropriate training. And we want to be mindful of the workforce and being able to utilize different individuals with different skill sets when delivering this service. Care management requirements also include proactive and intentional outreach and engagement with the individual to build necessary trust and support. And again, those meetings that I mentioned. So when we talk about deliberate and coordinated assessment and planning to prevent disengagement from services and assess and mitigate risks for individuals, we're talking about risks that may include things like risk of grave disability, risk of danger to self or others, institutionalization, incarceration, overdose, out-of-home placement for youth. And so making sure that those risk assessments involve the individual and multidisciplinary team and are done on an ongoing basis. Care plans are specifically addressing prevention of and response to an individual disengaging from services. Care plans are including a crisis plan so that, and actually we've clarified that this is a psychiatric advance directive so that an individual's preferences for behavioral health treatment are known in the event of a crisis. I went through that a little bit faster, but I wanted to leave room for questions. And if I need to go back to any of those specific slides, I can as we answer these questions.
Thanks for that, Erica. We've been answering questions in the chat, but maybe be helpful in case anyone's joining by phone, we can kind of review what's been going on in the chat. So there was a question from Megan, prior auths are often denied. How does that work for timely service? And Tom responded, the BHA does not have direct authority regarding prior authorizations, but we do have an obligation to coordinate services in a way that does not create barriers for service. And Tom says he wants to raise this with healthcare policy and financing and work towards timely service. There was another question from Andrew. If the individual wants only virtual services, is face-to-face still required? In virtual, we mentioned virtual is acceptable when requested. Anything you would add to those, Erica, while we wait, if anyone else has a question?
No, I don't think so. In terms of the question around face-to-face, were we specifically talking about those care management contacts?
That's a good distinction. Andrew, was there a specific service you were thinking of?
I mean, really any particular service. We have a number of providers and clients who are remote. And so wondering about that component in order to serve rural and frontier Colorado.
Yeah, I think you raise an important point around serving our rural and frontier communities. I agree with Tom's answer that virtual services, when we're talking about all of these clinical services, yes. In terms of care management, based on stakeholder feedback, we had required those 2 face-to-face contacts annually. Reason being that when we're, this service was really developed to serve that specific population of high acuity individuals, and knowing that sometimes getting out there and outreaching them in the community is a key part of building that trust and rapport long term. And so I think we're certainly open to feedback around that. But as it is written right now, it is specifying that at least twice a year, those would be face-to-face contacts with the individual.
If I could also weigh in there, we have also gotten stakeholder feedback from some folks in rural areas that have said in certain circumstances, or maybe lots of circumstances, we shouldn't allow virtual visits because it may encourage people to seek services outside their community. And also what happens to a community if people are getting those types of services in other places, or perhaps, well, I'll just say other places. And what does it mean for supporting the infrastructure that's there? And I'll say I've never thought of it that way before, and I think that was an important point. So I just throw that out to this group also for consideration.
Yeah, I guess my comment around that would be, I would rather have a client define a community than the Chamber of Commerce. And, in terms of what the client needs, being flexible around that and making sure that, I guess maybe some language around contraindication or, client choice. Obviously, with my organization, we try to do face-to-face whenever possible, but there's just some clients where it's just not possible for whatever reason.
Right. Thank you for that, Andrew. I appreciate your insight and expertise on that. I think there was also another related chat, and this from Elizabeth, about how are we defining face-to-face? And I think we've run into this before, is that depending on the types of definitions you look at, face-to-face can be a virtual Zoom. Like technically we're all face-to-face right now. So if we mean like in the same room, we should probably say it that way. And I think that if memory serves, and Andrew, it might have been one of your old programs when you were at OBH, some children's services did require provision of services in the same room.
Yep. And I'm sure Stacy can fill you in on how that worked and how that's been adapted over time.
You don't want me to refer to you for further development of our rules in that way?
No.
Okay. I think back to Victoria and or Erica for other questions.
So we have a couple of raised hands. I saw Megan's hand first.
I yield to Jennifer.
All right, Jennifer, you're up.
You. So I have a question on care management. So is care management going to be based on medical necessity or acuity of somebody, or is it the expectation that every client within a system will get care management?
Thanks for that question. Right now, and I think part of your question is maybe the fact that these terms get used differently in different systems, and even within our system, and that's part of the ongoing confusion that we're trying to sort out ourselves as we write rules that are hopefully clear. When we are talking about care management, we are saying that this would be a service that is provided to a subset of individuals, and not everyone. We have designed the care coordination requirements in Chapter 3 to be those services that would be delivered to everyone receiving services from a behavioral health safety net provider. And there is certainly some overlap in those services. Like I mentioned, the care coordination requirements are part of the care management requirements, but some of the really specific requirements that we've added are not necessarily captured, and that would be the distinction there, that those services are being provided only to, or maybe like those frequency requirements in particular are only applying to care management that's being delivered to a subset of individuals.
So where would I find the requirements for care management, the subsets? Is that written anywhere I could look up to find out which particular client subsets and the criteria?
Like who would be receiving care management?
Yep.
Yeah, so that doesn't live within the rule in the same way that we don't say this is who receives outpatient within rules. We haven't defined that within our rules. Some of what and I will defer to Ryan on this also, but some of what the administrative rules will do is kind of identify across the continuum who is doing what, where are those responsibilities living. And so there might be more specificity there. But in terms of our rules, we're defining what those services are and what a provider is doing and required to do when they're providing that service, but not necessarily who is eligible for or receiving that service.
Thank you.
Yeah, but I'd just reiterate that, yeah, it would be based on an individual's assessed need, needing this level of care management.
And that would be predominantly the provider's clinical opinion?
Yep, based off of the requirements that we have for screening and assessment requirements to ensure people are getting to the right spot at the right time.
Thank you.
Megan, do you want to jump in?
Sure, real quick, just thank you. Person-centered in this space, I think, is very critical. And I think there needs to be consideration in rule in regards to the clients and their loved ones, really leading that and not just continuing to defer to perhaps discharge recommendations or something that becomes a mandate. Even when we're speaking about people who are perhaps in multiple systems, so that we are assuring that we are staying true to the value of person-centered care, and that in this care management plan, there's a clear understanding in rule that the clients and their loved ones should and will have the ability to either decline or ask for more appropriate services to serve that particular individual. Also including services that may be outside of traditional behavioral and mental health services. Thank you.
Thank you for that comment, Megan. We've definitely heard that from stakeholders, and I'm grateful to be hearing it again, and are working to incorporate some additional language into these chapters that really emphasizes that these service plans aren't just based on assessed needs that a clinician has determined, but then those goals are really person-centered and aligned with the individual's preferences, wants, needs, or preferences and wants really is what we're emphasizing there. So we appreciate that and are continuing to work on that, and certainly welcome additional feedback. If you have any written suggestions, we would be more than welcome to review those as we continue to revise this.
Thank you.
I'll also read some other chat comments. So Nancy said, it seems like safety net providers should be required to have a thoughtful policy on how and when they employ telehealth, in-home services, in-person services, and services delivered in the community outside of homes. These policies should be person-centered and identify how and when providers deploy services in various settings. And Tom responded, thanks, I think there is room for this in the equity plan portion, but defer to Erica. Erica, if you have any additional thoughts to share on that.
I think Tom makes a good point that the equity plan certainly had things like this in mind around identifying specific ways that providers can be appropriately deploying these different methodologies like telehealth and in-home services to reach populations that maybe are not coming into clinics, and certainly with the outreach and engagement services that are outlined in Chapter 5 as well. And I think maybe more broadly, we can look at how providers are considering that at even like at a screening level of determining the appropriate means of providing services for that individual, in the same way that we've built in some of that specificity at the care coordination level with, identifying preferred modes of communication and things like that.
Great, thank you for that. I will note that we have 3 minutes left in our town hall for today. So we'll pause if anyone is typing or writing anything into the chat or wants to raise a hand. We probably have time for one more question today, if there's one out there. All right, not seeing any so far. In that case, we can go ahead and start wrapping up. I want to say thank you to all of you who joined us today to hear about these updated chapters 3 and 4. Thank you so much to Erica for walking us through all of that and answering all of these questions. Mel has dropped in the chat a lot of our important links and info to have. So we have a link to our website that is our one-stop shop for all things rules, which includes our stakeholder calendar if you want to attend any other events. We also have some in-person events coming up. Next week we'll be in Canyon City, and then I believe Durango, Grand Junction, and Pueblo. We have feedback in our feedback survey is open. We have our email inbox in the chat as well. If you would like to send us any additional questions or feedback, we are accepting feedback through June 23rd. And just thank you all for showing up today and engaging with us and bringing your great questions. So again, thank you very much for your time, and we'll probably see you again soon. Thanks, everyone.